introduce to you the chair that made all of this happen today, and it is Dr. Kristen Wright who will be introducing the succeeding talks.
Thank you, Dr. White. Good morning. So welcome, and we have our first student speaker of the day. Student Dr. Amanda Waller will be talking to us about why we ethically disapprove of female genital mutilation, an analysis of varying genital cutting practices and what they illustrate.
All right. Can everybody hear me okay? Is this an okay volume? So for my research, what I did was actually kind of a meta-analysis. I kind of looked at a lot of other research, and what I wanted to do was kind of look at why ethicists, and not just ethicists, also a lot of NGOs, some medical colleges have made decisions that things are not ethically okay. So I looked at a lot of reasoning that was specific to FGM as to why it was not approved of. And then I did the same thing for 2 other genital cutting practices to kind of compare, and then I drew my own conclusions from that. So you'll see I'll kind of go through those 3 different procedures sequentially, and I'll try and explain what those are. And the reason I did this is that FGM, or female genital mutilation, tends to be one of the more medically severe of these genital alteration practices that we do on minors. So not only does FGM tend to dominate the conversation ethically, but also the medical consequences are what tend to dominate the conversation when we talk about FGM. And my goal, after looking through all the research, kind of what I came down to thinking is that I want to shift that focus a little bit from just the medical sequelae to also kind of considering the emotional and the symbolic sequelae, because I think those are equally or maybe even more important. So what is FGM? Female genital mutilation, you'll sometimes hear referred to as female circumcision. It's synonymous, but for my presentation, I'll only use the FGM title. It's a coming-of-age procedure that is practiced throughout the world, most prominently in parts of Africa and Southeast Asia, but really practiced all over, especially when immigrants from some of those areas have moved. And medically or anatomically, it consists of removal partially or totally of the clitoris, partial or total removal of the labia minora, sometimes the majora, and then in the more severe types, actual sewing of the labia together. And I'll have the pictures here in a second to kind of help see what that looks like. But a few things about this to kind of keep in mind is that, one, usually this procedure is not done by a medical professional. It's more likely to be a spiritual leader, community leader, cultural leader, someone who's going to fill that kind of role. It's also not going to be typically done using sterile technique or with any type of anesthetic. And I'm not saying that that's a blanket statement, but that's kind of the typical trend you're going to see in a lot of the countries where these practices originate. Other things to keep in mind is that there are 0 medical benefits that have been found associated with FGM, but in terms of the risks, you can imagine there are definitely numerous risks. So infection, excessive bleeding, lifelong pain without any trauma or touch is actually very common, but almost every woman is going to have pain with intercourse or any kind of vaginal trauma. And especially for the severe type 3 that I'll show here, there are really dangerous obstetric outcomes. So this picture, let's see, is kind of meant to help illustrate. So in the top pictures, the green is what is actually removed. So you can't totally see what that would look like. Actually, type 1 I've seen, and if you see a woman with this, it might even just be partial removal of the clitoris or removal of the hood. You might not even notice at first if you're doing a pelvic exam that something is kind of off, but once you get to the type 2s, you're gonna see scar tissue and things are not gonna look like typical anatomy. You're really gonna notice it. And then type 3 are the more severe types, and you definitely can see this in Kansas City. There are a number of immigrant populations where this is the more common practice. And especially this bottom right one, you can imagine that not only passing a tampon through that, but through like a penis or a baby's head is gonna be possibly impossible. So what tends to happen in obstetric situations, especially not in this country, but in areas where they may not have access to an obstetrician, is they'll wait while this woman is in labor until the baby's head descends, and they'll wait to kind of cut that back open. and sometimes they can cut baby's head pretty severely. So there are a lot of bad outcomes for the babies in that situation. And then they'll sew mom back up, she'll get pregnant again, they'll recut it, and it's kind of rudimentary. It's not a very well medically processed procedure. So that's kind of the basic of what those look like. So next I want to talk about the other two genital cutting practices that I want to compare to. So these are separate from FGM. The first one is genital nicking, which is a relatively new theorized procedure. It is being done, so it's not just theorized, but it's kind of been proposed in this country and not necessarily accepted yet. And it's meant to be a symbolic replacement of FGM. People that were involved in cities that have a large amount of mostly African immigrants, but immigrants from areas where this is common, whether they're public health officials, gynecologists, ethicists, have kind of worked together to come up with this idea, along with a lot of FGM survivors. And all it really entails is using a sterile needle, and I've seen a couple articles about using a sterile scalpel to nick the clitoral head, or in this picture, the glands, so it's gonna be this part right here. And while that's a very tender area, it's really, medically, this procedure is not gonna have many side effects or any kind of negative medical outcomes. It wouldn't involve any stitching, it wouldn't involve any packing, it'd be done by a medical professional, sterile environment, so it wouldn't be that different than getting just a saline injection in your arm, other than the fact that, it, like I said, it's a more sensitive tissue. So it's being done in other countries more than it is here, but in comparison to FGM, significantly this has almost no medical consequences. Obviously it could have some, but this is incredibly low risk. And the third procedure I want to compare and talk about is male circumcision. And I feel like that's probably the procedure that people in this room are most familiar with because it's so common in the United States. So as you may know, male circumcision involves surgically removing the foreskin of the penis. It's probably going to be associated with temporary pain depending on who's doing it. They might use a penile block while they're doing the procedure, but that can wear off, and so babies can be uncomfortable. They might have some swelling, some bleeding. Infections can happen, and I think it's important to acknowledge that there can be serious adverse effects sometimes from male circumcision. We think of it as a very low-risk procedure, but rarely there are going to be babies that are circumcised that have lifelong consequences because of that procedure, whether it was due to an infection or the procedure was botched or there was underlying anatomy that wasn't known about, like hypospadias or something. Rarely there can be serious consequences from male circumcision. And the reason I say that is to compare it to the genital nicking that I just talked about, and just to show that male circumcision compared to nicking is more invasive and carries more medical risk for potentially bad outcomes. And now I kind of want to go back through and talk about how the ethical community has responded to these three things. And when I say ethical community, I really looked into a lot of ethical journals. I looked into international health agencies like the World Health Organization, as well as the American Academy of Pediatrics and a few other medical colleges. So FGM is actually the easiest because basically everyone's opposed to it. International health agencies like the WHO, almost all the ethical literature I could find, even a lot of people from these communities, a lot of FGM survivors, are almost all unanimously opposed to FGM, citing it as either a violation of human rights or an example of sexual violence, gender violence. So other than communities that maybe still want to practice this procedure, there's not much ethical debate out there. Interestingly, when I started looking into this, I was surprised to find that ethicists are actually very also opposed to genital nicking. And it's not quite as unanimous as FGM. There are definitely ethicists out there that are kind of more on the public health boat saying, you know, for medical consequences, we'd really rather have genital nicking happen to these young girls than this horrific FGM procedure. But overall, I actually could find more articles that were opposed or outraged at this idea of genital nicking than I could find articles just talking about what genital nicking was. And the people that are opposed say that nicking is still an example of sexual violence, even if it's not physiologically or medically controlling someone or suppressing someone's sexual desires, it's symbolically or emotionally still doing that same thing. So it's really not any better, and it's not a compromise solution. So that's kind of overall, I'd say the takeaway or majority response has been, this is also not okay. And then thirdly is the male circumcision, which is also not unanimous. There are definitely pediatricians, ethicists, groups out there that are opposed to male circumcision or think that it's not necessary or carries too much risk. But overall, ethicists, pediatricians, the American Academy of Pediatrics all seem okay with this happening. And I think in this country especially, that's demonstrated by the fact that we have about a 70% male circumcision rate of infants that are being born. We do over 1 million of these procedures on male infants in hospitals every year. The American Academy of Pediatrics, like I said, is totally on board with it. And so by action as well as by the literature that's out there, overall, I'd say a majority response was male circumcision is okay. And when I first started looking into this, that was interesting to me because I was thinking of medical consequences, and the genital nicking procedure is so low risk, even compared to male circumcision, yet male circumcision in this country was more widely accepted. So that was kind of the thing that I had to deal with and think about. And the reason that I kind of came up thinking about this research was a family I dealt with, so I kind of just want to talk about that family. And I've changed some details just for their privacy, but basically it was an immigrant family from a country in Africa, and I met them in Kansas City. And they had 2 kids that were born in this country, a son and daughter. And their son was circumcised without any complications at birth. And then when he was 4, he was diagnosed with sickle cell anemia. And so then when I met him, he was actually 10, but for the previous 6 years, he'd been in and out of the hospital, had a lot of complications, a lot of issues, a lot of pain crises. And I think a lot of kids who have a chronic illness like that tend to kind of mature more quickly or become used to a hospital setting, but this boy had not done that at all. He had really learned to associate pain crises with hospitals, so he was terrified of hospitals. He hated it. Every single time he was there, he was kicking and screaming and extremely upset. Even if he wasn't having a pain crisis, he just would freak out. So his parents were really struggling with constantly having to bring him in for his care, whether it was upkeep care or care because of something that happened, a fever, pain crises. And his situation was certainly difficult. But I mean, they knew what was best for him. They were his parents. He needed medical attention, and they would often bring him in against his will. The same family's daughter was 12, and she was soon turning 13, and they were considering taking her back to their country of origin to have FGM done on her, like her mother had done. And to this family, it didn't seem very different to them than what they were putting their son through. And I think from a medical perspective, especially a Western medical perspective, it's easy to say like, well, we're putting their son through pain and we're holding him down against his will and we're doing these things to him because it's for his own good and it could save his life or could improve the quality of his life. And for their daughter, it's only going to, cause her pain, make things worse. She's not going to get any benefit from it. But to these parents, their perspective was their son had a medical issue and he needed intervention. He needed painful intervention that he didn't want to improve his quality of life long term. For their daughter, I think they genuinely believed that she would not be eligible for marriage in their community, so no one would marry her. She wouldn't be able to have any kids. She wouldn't have a family if she didn't have FGM performed on her. And in their community, things such as marriage and children and family were so important and held so high that was equally a very important quality of life issue to them. So it would have been devastating if she wouldn't have been able to have those things. So other than just saying that FGM is not medically indicated, I felt like I needed a better explanation for myself as to why I was okay with the idea that their son was consistently being held down, traumatized, hated being in the hospital, but the idea of that being done to their daughter still just wasn't okay. So that family was kind of like the case that led me to looking into this. And the answer is kind of what I decided or concluded, and that's that it doesn't really matter what we're doing to these kids, and that it matters more why we're doing it. And for any pediatricians in the room or family practice, we hurt kids a lot. I don't know if anyone's been in a peds office or worked with nurses that have to be like the injection nurses who give all the vaccines, but they hold 3-year-olds, 4-year-olds down, they're kicking, screaming, they're terrified, and they give them shots 4 at a time in a leg. So like that's something we do. It's not unheard of, and I think as a medical community, we kind of look past it because we feel justified in whatever we're doing. We feel like there's a good reason that we're hurting kids. But when it comes to FGM and even the clitoral nicking procedure, most ethicists and also the American Academy of Pediatrics are 100% opposed to any form of female genital alteration of minors. And unlike male circumcision, even this very low-risk nicking procedure is still intended to symbolically or physiologically suppress the sexual desires and control women's bodies. And male circumcision doesn't usually carry those same symbolic connotations. So that is why it was such a big difference, not the medical consequences at all. So that kind of just leads me to my final statement, which is that our emotional impressions are actually maybe even more important as to whether or not we approve of a genital cutting procedure on a minor than the medical consequences. And the reason I think this can help us as care providers is that when we're talking to a family about potentially changing the appearance or the function of their child's genitalia, we need to acknowledge the symbolic and emotional consequences rather than just the medical outcomes. So here are my sources. And I would like to thank Britt Johnson, especially for helping me with this whole presentation, PowerPoint, poster, etc., the bioethics department, and the research department.
We have time for a few questions. And if you'd like to ask a question, please work your way down to the microphones on either aisle.
Good morning, and thank you for this wonderful and interesting talk. I believe it's a talk that I don't hear much about in the community, and I'm happy to see that there is actually an interest in the FGM movement. My question to you is, I'm soft-spoken.
No, it's okay.
I'll project a little louder. I wanted to know if there's been any outreach to the actual communities that have been doing this for alternatives. Like, instead of the FGM, has there been a talk to the people discussing the nicking? I know it's a cultural aspect to these communities, so I wanted to know if there actually has been an outreach.
So when the nicking was first talked about, or at least the oldest article I can find that it first started being a discussion in the United States, was a group of gynecologists in Seattle, Washington. I think there's a large enough immigrant population there that are affected by this that a group of gynecologists, public health officials, and probably some community leaders, I think, were involved. And they proposed this idea of genital nicking as a procedure that gynecologists could offer. And since they did that, the American Academy of Pediatrics has come out with their statement saying it's not acceptable. It is not okay to have any form of genital modification of female minor patients. And because of that statement and because of all the negative feedback I've talked about, kind of being able to see out there, the medical community has kind of had to back off in terms of offering any type of replacement procedure. And in terms of education, that is really dependent on the community. So if there are prominent community leaders who are either survivors or they're advocates against it, who want to take on that role and work with health officials, then I think kind of in a pocket fashion across the country, you'll see that. And you'll see, and I've heard of entire cities where if enough people become involved and they're all willing, like if they hear like that a bunch of other families aren't having this done, then they're going to feel more comfortable if their daughter's also not cut, because it's like, well, if this is going to be the trend, then she's no longer going to be singled out, or her potential for marriage might not be as affected as we thought. But it kind of has to happen almost within the communities first, from what I could find. And it's almost like a pocket type pattern. Like as one community like decides as a group, then another will. But in Kansas City, all I've really heard about in terms of what's offered is I know they get a lot of Somali women at Research Hospital, and I know that there are gynecologists and obstetricians that are willing to work with them specifically during their labor and delivery, and are willing to re-sew them after they deliver. Otherwise, those women wouldn't go see obstetricians or gynecologists. So that's the only thing I've heard about specific to Kansas City. I know there are community leaders, but I'm not totally sure what the status is. Does that kind of answer your question?
Yes, thank you.
Okay. Any other questions? All right, thank you.